Good morning, good evening. Thank you for joining us today for this first webinar. On behalf of the Cleaner Catalyst partners at the consortia, we would like to welcome to this first webinar. That today we will discuss. We have a great panelist. Our webinar is called Cleaner Catalyst Briefing on New WHO Global Air Quality Guidelines. For those of you who may not know about the Cleaner Catalyst, we would like to share with you a video that explains what is the Cleaner Catalyst.
Air pollution is choking people and cities around the world at alarming rates. Globally, 9 out of 10 people breathe unhealthy air. Air pollution is undermining the well-being of billions of people, especially vulnerable communities who bear the heaviest burden. It is the largest environmental health risk in the world, responsible for 6 million premature deaths a year, more than HIV/AIDS, malaria, and tuberculosis combined. From cars to power plants, many of the same air pollutants that damage our lungs damage our climate. Rapidly urbanizing regions in developing countries are on the front lines of this global health and climate crisis. Urgent action is needed to identify and accelerate solutions. The U.S. Agency for International Development is launching a bold initiative to improve air quality in cities around the world. The Clean Air Catalyst program is a partnership with the World Resources Institute, Environmental Defense Fund, and a global consortium that is developing local solutions with governments, communities, and the private sector. Starting in 2 pilot cities, Indore, India, and Jakarta, Indonesia. Reducing air pollutants improves public health, reduces poverty and inequality, and lessens climate change impacts. From advancing clean energy access, to developing alternatives to burning crops, to supporting the transition to zero-emission transportation, Clean Air Catalyst is developing solutions on the ground and in the air, because everybody deserves the right to breathe clean air.
Welcome back. My name is Beatriz Cárdenas. I am the Air Quality Director of WRI Mexico. I am also very lucky to be part of the Cleaner Catalyst. I am co-chairing along Ramon Alvarez, the science team. And we welcome you all. Today we will have a webinar to discuss the new air quality WHO new guidelines. So as you know, after 2000, the first time after 2005, the World Health Organization has updated its recommendation to air quality levels based on the most recent evidence on health effects. So today we will discuss that. We have a great group of panelists. We will start with Dr. Michael Brouwer. He's the member of the WHO Development Group, and as you know, he will give us an overview of health science underpinning the development of guidelines and intended use. Later, we will have also Dr. Dr. Sumi Mehta. She is a senior epidemiologist from the Global Health, Environmental Health and Vital Strategies. And she will help us to understand through some examples of health-based source awareness work around the world and implications for health-based source awareness, the work that we are doing in the Cleaner Catalyst. And finally, we will have Dr. Ananya Roy. She is a senior health scientist from the Global Environmental Health and from the Environmental Defense Fund. So thank you so much. We will have, after their presentations, we will have some time for Q&A, for questions and answers. So please help us posting your questions, your comments, and because we will have time to discuss that. So please, Dr. Michael Brouwer, could you please share with us what about the new WHO guidelines? Thank you.
Sure. Thank you very much for the introduction, and it's a pleasure to be here. So I'm going to give some background on the WHO Ambient Air Quality Guidelines 2021. First of all, just why are we all here? I think it's widely appreciated now that air pollution is a major risk factor for global health. Depending on the statistics you'd follow, some 4 million deaths per year attributable to air pollution. Somewhere around 7% of all deaths are attributable to air pollution, and the costs of this are staggering. More than $5 trillion a year in welfare losses. We've had a World Health Organization air quality guidelines for a long time. The most recent update was in 2005. And in 2019, almost the entire world's population, so 92% of the global population, actually lived in areas where individuals would be exposed to levels above those current air quality guidelines. So you may ask yourself, actually, why lower them if we weren't even meeting the older guidelines? And we'll hopefully get into some reasons and some background for that in a minute. But this is really just a sense of the scope of the problem. So what are the guidelines? The air quality guidelines identify levels of air quality to protect public health worldwide. They're not binding. These are not standards. I would say they're our best estimate of the levels of air quality at which we have evidence of adverse effects on human populations. So if we lower levels to these guidelines, we're doing our best efforts to protect public health. We have air quality guideline levels for a select number of air pollutants. In this revision or this update of the guidelines, the pollutants that were focal pollutants were particulate matter, so PM 2.5, particles smaller than 2.5 microns, and PM 10, ozone, nitrogen dioxide, sulfur dioxide, and carbon monoxide. The World Health Organization does have air quality guidelines for a larger number of compounds, but those have not been updated in this most recent update. And I'll get into more detail at the end about how these guideline levels can be used and to actually inform policy and hopefully to design measures to actually manage air quality and reduce its impacts on population health. So what's new? As I mentioned, there are previously guidelines. The most recent update before this year was in 2005. And since that time, we've seen really a dramatic increase in both the quantity, but also the quality and the scope of evidence undermining the relationship between air pollution and its impacts on health. In particular, we have now studies of short-term exposure impacts, so daily variation in air pollution and its impacts on health from many locations outside of North America and Western Europe, which was not the case in 2005. So some recent analyses, for example, are providing these estimates of impacts or studies of impacts from more than 600 different countries, 600 different cities around the world. We also have many studies now of long-term exposure impacts at very low levels, and I'll get into that in more detail later in the presentation. We've also seen an expansion of the health outcomes affected by air pollution. Most people can appreciate the impacts on respiratory health, but we now have a large body of literature effects on the cardiovascular system, on type 2 diabetes, and expanding even into outcomes such as dementia, mental health, chronic kidney disease, et cetera, on and on and on. And the scientific methodology has improved, as has the scale of studies. We now rather routinely have studies with tens of millions of people being followed to understand the impacts of air pollution on populations. In addition, we have improved insight on the sources of these emissions and as I just showed you, the contribution of air pollutant to the global burden of disease. So after the systematic review that I'll go into in more detail, several of the air quality guideline levels are now lower than they were 15 years ago. And in addition, we also have new air quality guideline levels for a number of pollutant measures. So these are the air quality guideline levels. You can see on the left-hand column different pollutants and different averaging times. The air quality guideline levels on the far right-hand column. There are also interim targets, which I'll explain in more detail. So we both have these levels and then interim targets, which are used to guide reduction efforts. And then in addition, there, as part of the air quality guidelines release, there are good practice statements for several different types of particulate matter air pollution that are relevant to health, but for which evidence is really insufficient to set numeric guideline levels. But these good practice statements provide information on the pollutants and on their management and control. The pollutants that, if you can see, that are underlined here, so ozone, peak season ozone, and daily levels of nitrogen dioxide and daily levels of carbon monoxide, these are actually new guideline levels that new guidelines that did not exist in 2005 as well. So both the numbers have changed, but also actually new metrics have been included in this update. So these interim targets are quite important, and they're really intended to guide reduction efforts for the achievement of the air quality guideline levels. Previously, they've been used by several countries actually as national standards. So for example, the previous interim target 1 for particulate matter was used by China as their class 2 standard. And the concept here is really that if you are in a location at which current levels are well above the recommended air quality guideline levels, these interim targets really provide a pathway for you to move towards those air quality guideline levels. What we understand about the science of air quality impacts on health is there's actually really no evidence to detect a fully safe level. So even though we have these new guideline levels and they're quite low, we actually do have studies even today, and I expect we will have more in the future, that are showing adverse impacts at levels actually below these guidelines. So the important thing is actually not necessarily do you meet or do you not meet the guideline levels, but actually are you moving from a higher level to a lower level? And we know that if you move down to a lower level of exposure for the population, there are health benefits to that population. So again, it's really about the movement from wherever you are towards a lower level. These good practice statements, without getting into too much detail, cover 3 different types of particulate matter. One are sand and dust storms, which is a particular problem, especially in the Middle East and parts of Northern Africa, but also impacts air quality throughout the world. In addition, elemental carbon or black carbon, which is also an important climate forcing pollutant. And ultrafine particles, so the very, very smallest fraction of particles. These guidelines provide information on measurement programs, forecasting programs, and in some cases, measures that can be implemented to reduce emissions, working towards perhaps the eventual development of air quality standards for these types of particulate matter. So how are these guidelines developed? There was quite a systematic process. The whole procedure took about 5 years, and it involved a number of different groups. I was part of the guideline development group, which consisted of both air quality experts and national and regional representatives from throughout the world, around 20 different people representing all regions of the world. This guideline development group worked together with a systematic review team that did specific systematic reviews of the evidence relating these pollutants to health impacts, with oversight from a steering group from the World Health Organization and methodologic experts, both on systematic reviews and on guideline development itself. So overall, it was quite a highly systematic process. And just to give you a sense of the methodology, it was really based upon conduct of systematic reviews of epidemiologic studies of specific critical health outcomes. So we did not review all health outcomes related to pollutants, but specific ones that we thought would be critical for underpinning these guidelines, and with a particular focus on mortality impacts. These systematic reviews had the goal of really assessing the certainty of the body of evidence resulting from the literature, and trying to address the question of, in any population, including susceptible subgroups, what is the increase in risk per unit increase in air pollution observed in studies that are relevant for the health outcome and the exposure duration of interest. So that was really the task statement for the systematic reviews. There are 6 separate systematic reviews. Some of them actually include multiple pollutants. These have all now been published. They're publicly available. So you can look at all the studies that have been included in these papers, how the evidence was graded, and the numeric quantities from each of the studies, as well as summary measures. Those systematic reviews were then used to answer this question, which is really what was used in the formulation of the guideline itself. What is the lowest concentration that produces a measurable increase in risk? From the perspective of long-term air quality guidelines, this was formulated as the mean of the lowest 5th percentiles of study population distributions. And I'll illustrate this with an example in a minute. The idea here is that we're looking across the body of literature, taking studies that were conducted at the lowest concentrations, and within each of those studies, what is the lowest concentration, or essentially the lowest, the 5th percentile concentration that was actually used to measure the relationship between air pollution and health risk. The short-term guidelines were actually aligned with these long-term air quality guidelines. And this is quite important because if a particular jurisdiction is going to be using this for management, we'd like the air quality, whether you're meeting the short-term air quality guidelines or the long-term air quality guidelines, that actually be aligned. If that's not aligned, you may have situations where actions would be taken, for example, just focused on short-term air quality guidelines, what we would call peak shaving. So where you're actually just trying to eliminate or reduce high exceedances of air quality levels, but actually not addressing the long-term exposures that also have impacts on health. So it's very important that these were aligned. And really what we did was use the relationship between long-term averages and short-term levels to look at what the 99th percentile distributions of 24-hour concentrations that would match the long-term air quality guideline. So that's quite mathematical, but the basic premise here is that these two kinds of metrics should align. So in the previous, so just with an example of particulate matter, in the previous iteration of the air quality guidelines, there was only one study really that was used that had levels close to guideline levels. And what we actually did was took the lowest level of that single study. And that really was the basis for the 2005 air quality guideline set at 10 micrograms per cubic meter. Nowadays, we actually have many studies. So this is just one example. A study that was recently completed in a large cohort of Medicare enrollees in the US. And you can see that the levels of exposure in this population were both above the previous air quality guideline of 10, but also went way below it. And as this example here, where the new air quality guideline is at the low end of the distribution of this particular study. But it wasn't just one study. So this is a list of multiple studies that had been part of the systematic review, had been graded for high quality evidence. And where you can see in the red text here, the 5th percentile of the concentrations in those studies where there was an elevated risk for air pollution in relation to mortality. These are the 5th percentiles. They range from 3 micrograms per cubic meter to 7.8. And we simply took a weighted average of these concentrations to come up with the air quality guideline level, which is set at 5 micrograms per cubic meter. And then these interim targets are just multiples of the air quality guideline level. The interim target 4 is actually the old equivalent to the old air quality guideline, and the interim targets 1 through 3 have not changed at all since the 2005 iteration. So again, if countries were trying to move, for example, from a level of interim target 1 to interim target 2, that has not changed. All that has changed is really at the low end here, this new interim target 4 and having the new air quality guideline level. So just in closing, what can countries do with the air quality guidelines? So as I've already stated, they can be used to update or to target legally binding air quality standards and to develop implementation policies for jurisdictions to meet those standards. It's well recognized that to actually achieve adequate air quality, we need multi-sectoral cooperation at multiple levels, for example, including health ministries, ministries of transport, et cetera. These guidelines can also be used to reduce health inequities related to air pollution. And we'll hear more about that later, actually in the webinar. And these actions are going to require cooperation of multiple stakeholders and sectors. And just to point out that the health sector is crucial in raising awareness, and there's already quite a lot of activity that's underway from the health sector. So this is an example of uptake of air quality guidelines in air quality standards across the world. This was based on the older iteration, but you can see that there are many countries that still do not have standards, but many of them that do have implemented standards that align with the air quality guidelines. And we would hope now over time that more countries will implement standards and that there will be more alignment with the air quality guidelines that have just been updated. This is just an example of health sector action. This is a recent initiative by the World Heart Federation. And it's quite an impressive sort of series of action statements, both to engage individuals in the healthcare sector, as well as for them to work together with partners in other sectors, municipal sectors, for example, to reduce the health impacts of air pollution. So this is one example of the health sector getting involved now in air quality reductions. Also, I think as many people can appreciate, there's a link between air pollution and climate change. Many of these sources that are contributing to air pollution are the same sources that are contributing to global warming. So mitigating emissions from air pollution will also reduce the emissions contributing to climate change. And from both those pathways, from the direct pathway of air pollution or those emissions and their contribution to climate change, we will have protection of health. And again, just to close, I can't stress enough this concept of continuous exposure reduction. So the idea of really what's important is moving from wherever a location is now towards the guideline levels, and not whether or not you meet them, but actually are you improving year in, year out. And with that, I will close. Thank you.
Thank you so much, Michael. I guess this was a great explanation. Many of us were wondering how these new guidelines were established, what is behind, and what are the questions that these, and as you mentioned, what are these guidelines are trying to push in terms of reducing and protecting human health. There are a couple of questions that maybe before we go, if you can answer very briefly, Michael. It's one related to, well, very quickly, is there any guidelines for indoor air quality?
Yeah, that's a great question. These guidelines actually apply everywhere. So they do apply indoors as well. So they're really just at what level do you experience adverse health impacts. The World Health Organization does have additional guidelines for indoor air quality, which are more focused on sort of, for example, for household air pollution, are focused on sort of technologies and types of fuels and stove combinations. So there are additional air quality guidelines specific to indoor air, but these apply everywhere.
There's another question regarding the conversion, how to convert between micrograms per cubic meter per parts per billion. So there's a quick question about how to make a conversion from US national standards from ozone to the guidelines.
Sure. I'll in a minute, I'll give you a link in the chat on how to do that. This sort of goes back to your first year chemistry, how to do these conversions. So I'll give you some guidance on that.
Great. And there is one more question that maybe you can help us to answer while we have the rest, and then we can come back at the end, which is related to the average 5% percentile concentration in different countries. So do you want to comment about it?
Yeah, I can just say very quickly that we screen the entire literature, so all countries in the world, but as you can appreciate, it is typically only high-income countries where the lowest levels were at these very low concentrations. So a 5th percentile concentration in a country that has high levels of air pollution would be well above the 5th percentile, for example, in a country like Canada that has much lower levels.
Great. Well, thank you so much, Michael, and please ask your questions because we will have some time at the end. So now we will continue with Dr. Sumi Mehta. As I mentioned, she is the senior epidemiologist of global environmental health in Vital Strategies. And so please, Sumi.
Thank you, Beatrice, and I hope everybody can see my screen okay.
Yes, it's fine.
Okay, great. Thank you so much also to Dr. Brower for his very clear presentation. And in fact, I'm really going to start off emphasizing, I think, what he wanted to emphasize at the end, which is that, you know, we really feel from a public health perspective that the air quality guidelines should form the basis of local air quality standards. I think, you know, as Mike mentioned, we really see now very clearly that there's no safe level of air pollution. And so any incremental improvements in air quality will have substantial health benefits. And in fact, we see that if we were to achieve health-based guidelines everywhere, that around 80% of the air pollution related deaths happening every year could actually be prevented. And, you know, in order to get there, of course, these interim targets that Dr. Brower described are really important so that we can really help to meet countries where they are in order to really continue to encourage continuous and incremental progress. And as we're thinking about this, and as we'll talk about throughout the rest of this seminar as well, really when we're thinking about the implementation implications, that the local implementation of these standards should also really include monitoring to evaluate compliance in population centers to be able to really see that we're going to get the impacts that we'd like to see at the end of the day. So one of the things that I think is really promising that related to these new guidelines is that we actually see that if you're looking at the national alert levels, so like the air quality indices, and I've just given you here as an illustrative example, a couple of different mappings of different air quality indices from different countries and regions here, that these are actually very well aligned with the short-term PM 2.5 guideline levels. And so you can see here for most of these places, you know, if we're looking at the short-term impacts, the air quality guideline, which is given here at the very bottom in the green line, as well as some of the interim targets, these map pretty nicely when you're thinking about the short-term impacts. And so I think the challenge that we have really then is to think about how can we better characterize and also communicate the impact of longer term exposures to air pollution and then its resulting impacts on health as well. So just to give you an example here, and this is an example using data from Jakarta, Indonesia, compared with their national ambient air quality standards and the WHO guideline levels, you can see here kind of a larger discrepancy. If you look at just the column on the left here, which is the PM 2.5, you can actually see that we still have some substantial progress to be made towards moving down from the national standard, which is equivalent to the interim target 3, further down towards the air quality guideline. And so as we think about this, of course, we know that the long-term exposures are going to have the biggest impact on public health. And so, this is really something important to keep in mind. And, as we're thinking about this more broadly, I mean, just to keep this in context, as we're thinking about really equity and really focusing in on the most vulnerable and susceptible populations, it's good to keep in mind that air pollution-related illness and death are not equally distributed. And so you can see here in this map, for example, that some regions also, bear a much larger burden of disease, both illness as well as death from air pollution. In particular, of course, this affects the Southeast Asia and the Western Pacific region, but also increasingly is relevant to the Africa region. And we also know that air pollution affects people differently by age. And so you can see here, if you actually look at the burden of disease from air pollution by age, that it really affects, we have impacts early on in life and then very much among the elderly as well. And this is because of both differences in underlying health status, as well as difference in the prevalence of diseases that are associated with air pollution. And so, just to also remind everybody that we know that air pollution impacts people across the different life stages, starting in the womb and then all the way through the life course. But depending on the population distribution, it can really have a big difference. And just to emphasize this further, if you're looking at the population level, the differences in the age distribution of the population really makes a difference as a result. So just to illustrate here, if you see the population pyramid for Ethiopia here on the left, compared to India on the right, you can just see the difference in the distribution, which with a much younger population in Ethiopia compared to a slightly more beehive-shaped population in India. And so you can imagine then that the burden of disease and the population that's going to be most vulnerable is really going to be affecting a lot more of the younger age groups. The children's health is going to continue to be a much larger issue for air pollution related disease in Ethiopia, whereas the non-communicable diseases, kind of chronic cardiovascular and pulmonary disease, is going to be of greater concern in India, for example. Similarly, just to emphasize that at the population level, differences in exposure and average exposures to pollution really matters. And you can see here the difference across different countries in annual average PM 2.5 concentrations, also certainly not equally distributed geographically. And here too, we see really the higher concentrations that are experienced in the Southeast Asia, Western Pacific, and Sub-Saharan African region as well. But, excuse me, as we think about this, and particularly as we're thinking about inequities, it's really important to also think about the fact that inequities can really play out very differently across geographies. And so as we're really thinking about this carefully, and this will something that we're really thinking about as part of the Clean Air Catalyst work, we need to really think about how these inequities are played out. So for example, are the poor more exposed? And what are the reasons for increased exposure among the poor, for example? Are the poor more susceptible due to age, due to competing risk factors, or perhaps due to underlying health status? Are there certain neighborhoods that are closer to leading sources of pollution that we may want to really focus in on? And finally, how do different lifestyles also impact exposures? This could be, various aspects of life and how life is lived, whether it's commuting patterns, different cooking or heating practices, different occupations, et cetera, et cetera. So I'm just going to give you a couple of examples to just show how this can be quite different across different places. Excuse me. So here you can see an example recently published from the United States, where you can really see here very clearly that people of color tends to be disproportionately exposed to fine particulate matter. You can see in these graphs, which show basically these figures showing differences in exposure of people of color in the little purple dots versus whites with the green dots here. And you can see that whether you're looking with the equity line in the middle for all of these graphs, that whether you're looking at state level exposure here in the first quadrant, whether you're looking at urban levels, urban areas or rural areas, and also across all different income levels, that we really see disproportionate levels of exposure among people of color in the United States. But if you look at the example of India, you'll see something, again, inequities, but playing out quite differently. Some of you may have seen this very nice kind of case study that was published in the New York Times about inequalities in air pollution in New Delhi, India, where they really looked at a tale of two children living in Delhi, which is, has the dubious distinction of being one of the world's most polluted cities. And you can see here that Monu on the left here, his average exposure to fine particulate matter when they measured was close to 150 micrograms per meter cubed, compared to around 37 micrograms per meter cubed of AMIA here on the right-hand side. And you can see here in the graph also very clear differences in the exposures that were measured during the morning period, depending on how they were going about their day. And this was also in the article, it also emphasizes really the different circumstances within the neighborhoods in which Monu and Amia live. So, just to give an example here again of how inequities in exposure and then associated impacts can really play out very differently from one place to another. And so, as we're thinking about this, we really are, very keen on trying to think about how we can better characterize and then address some of these inequities in exposure, in susceptibility, and also be able to address the resulting health effects, and really think about how we can do this for exposures and at the individual level, also thinking about the community level, and then more broadly at the population level. And this is something that I think people have been thinking about for a long time. It also shows really the good intersection of kind of household level exposures versus community and particularly urban level exposures, as opposed to some of the impacts that we also may see, again, getting back to the links between air quality and climate at the global level as well, and thinking about how we can really consider inequities at all of these different levels. And so, in terms of some of the implications here, just to wrap up, I think when we're thinking about clean air action for health, it's very important to prioritize efforts to really address the leading sources, really thinking about those leading sources of exposure for people. And as we do this, ideally to think about how we can reduce inequities in exposure as well as health impacts. And this really involves thinking about a lot of the different leading solutions for addressing leading sources. And I know that Ananya is going to speak a little bit more about this in her talk momentarily, but really, being able to give us and equip us with the right evidence that we need so that we can really be informed to understand for every dollar that we invest to reduce emissions to these different sources, how much public benefit, how much public health benefit will we really receive in return? And are we able to do this in a way, again, that can help to address some of the inequities and exposure and health that we'd like to address at the end of the day. Thanks.
Thank you, Sumi, for this great presentation. I guess you have now put us into the mind that not only having these guidelines is how to implement them. And I guess what you highlight is also the monitoring, how to evaluate that we are getting either complying with the guidelines or the target monitoring. And most importantly, what you have also put in our mind is the inequities, how to address inequities, who is exposed the most, and how can we, by identifying sources, also reduce this exposure. So thank you so much. I guess we will continue with the next talk, and then we will come back to questions. Thank you so much, Dr. Sumi. Now we will continue with Ananya Roy. As I mentioned, she is the Senior Health Specialist of the Global Environmental Health and Environmental Defense Fund. Please, Ananya.
Thank you so much. Good morning, I'm Ananya Roy. It's a pleasure to be here. The recent tightening of the WHO standards for fine particulate matter, nitrogen dioxide and ozone indicate that air pollution adversely affects health at even low levels. As we heard from Professor Brower, these new guidelines are based on systematic review and meta-analysis of the existing scientific evidence, along with input from international experts on air pollution's impacts on health. We've heard from both speakers before.
Are you planning to show any slides? Not yet.
Not yet.
Okay, great.
I'll bring up the slides as relevant. Every year, as we've heard before, every year air pollution is estimated to result in millions of premature deaths. If we are to consider the burden of disease due to air pollution, we must consider cities. Globally, over 4 billion people reside in urban areas, and overlapping population density and elevated air pollution means that large proportion of the burden is concentrated in cities. And lack of action on air pollution has resulted in communities and families bearing the burden of heart and lung disease, hospitalizations, emergency room visits, and premature mortality because of ongoing exposure to air pollution. PM 2.5 and NO2 are attributed to cause thousands of premature deaths and hundreds of childhood emergency department visits for asthma in the San Francisco Bay Area. Cairo, Kolkata, and Shanghai, among major cities, have over 20,000 deaths per year attributed to PM 2.5. Of the 4 million new pediatric asthma cases attributed to NO2 pollution, 64% of these occur in urban centers. So addressing air pollution in cities is one of the large public health opportunities of our time, at par with acting on tobacco or poor nutrition. And the WHO guidelines and interim targets provide important health-based milestones to guide decision-making. Action on air pollution begins with information and awareness, a shared understanding of levels of air pollution, its impacts on health, and the sources contributing to it. Currently, our best estimates indicate that most cities across the globe do not meet the new guidelines and have elevated levels of air pollution. For example, annual average PM 2.5 levels in Indore, a city in India, hover between 36 to 40 micrograms per meter cube. However, because monitoring of air pollution is sparse, we aren't certain which cities or areas within cities meet or don't meet air quality guidelines, or how much above the air quality guidelines they are. I'm going to just start sharing some slides now. What's going on here? Sorry. Just give me a second. I seem to have lost this. Excuse me. Technical glitches. There we go. Can everybody see my slides?
Yes.
Perfect. Sorry about that. Where was I? Apologies about this again. Yes, sorry. Okay, so, and even within cities, not everybody breathes the same air. So fixed regulatory monitors may not fully capture air pollution where people are in cities, where they live, work, and play. Working with Google Street View cars, air quality and health scientists, as well as community partners, we've carried out air pollution measurement, health assessment, and mapping campaigns at street-by-street resolution, and found that nitrogen dioxide levels varied 5 to 8 times across streets and blocks in Oakland. This variation in air pollution was associated with elevated risks in heart attacks amongst the elderly and contributed to disparities in the development of childhood asthma. It also revealed the stark racial and ethnic disparities in impacts of air pollution in the Bay Area. On average, neighborhoods with higher percentages of residents of color and higher levels of poverty were burdened by double the rate of asthma from traffic-related air pollution compared with predominantly white neighborhoods. Many of the areas with elevated air pollution were areas with high rates of truck traffic. And though not absolutely comparable, the long-term averages of nitrogen dioxide across many of the areas were above the new air quality guidelines, but below the US National Ambient Air Quality Standards. And community partners in West Oakland have used these insights to advocate, design, and support targeted emission reductions programs to address air pollution in their neighborhoods. Ongoing monitoring is required to continue to evaluate the efficacy of emission reduction programs and build accountability. And across monitors, even in Addis Ababa, PM 2.5 levels have varied up to nearly twofold, between 24 micrograms per meter cube to almost 42 micrograms per meter cube annually. And depending on which monitor was chosen, PM 2.5 was estimated to result between 900 to 2,000 lives lost per year. And while satellite models have provided invaluable estimates of air pollution, they too require accurate on-the-ground monitoring to develop accurate satellite estimates of air pollution. A report by UNICEF in 2019 estimated that only 6% of all African children live within 50 kilometers of an air pollution monitoring site. And in India, for example, there is just one monitor for every 6.8 million people. And so the WHO guidelines have not only called to increase monitoring to really understand, what the levels of air pollution are, but they also develop new concentration response functions as it pertains to exposures and health indicators, which are critical components of health impact or burden of disease assessments that can help communicate, build awareness, and develop momentum for action among communities. It can help decision makers and regulators evaluate trade-offs through benefit cost assessments, accounting for returns in investment to address air pollution in terms of human health benefits. Work done by scientists engaged in the Eastern Africa GeoHealth Hub estimate that 500 air pollution attributable deaths can be prevented if the city achieves the first of the interim targets of 35 micrograms per meter cube for particulate matter. And up to 2,000 premature deaths can be prevented if achieving the previous WHO guideline. And now the fourth interim target of 10 micrograms per meter cube. But addressing air pollution health impacts inherently requires limiting emissions from sources. But which sources? As the WHO air quality guideline levels become lower, it becomes imperative to identify underappreciated sources, improve the accuracy of emission inventories, and build a shared awareness of the contribution of sources to air pollution across cities to tailor air quality management solutions. These need to consider all feasible emission reductions across different sectors. Local data can build a shared understanding and aid local decision-making. In Houston, mobile monitoring was used to identify air pollution hotspots near local metal recyclers and concrete batch plants, both underappreciated sources. In London, Cambridge environmental research consultants were able to use refined emission inventories and fine-scale air quality modeling to better estimate the contribution of different source sectors to air pollution across cities. Through the USAID-funded Clean Air Catalyst program, we are now partnering with local scientists, community-based organizations, decision makers, and other stakeholders in Indore, India, Jakarta, Indonesia, and Addis, Ethiopia. The idea is to improve source awareness, identify solutions, and drive actions through partnerships. In terms of source awareness, we are working on identifying key pollution sources and strengthening scientific understanding. And in order to do that, we're expanding monitoring of PM 2.5 and other health and climate relevant pollutants through fixed and mobile monitoring. Monitoring sites are being selected to capture the variability of pollutant exposures to the population and higher risk and sensitive or disadvantaged populations. We are developing neighborhood scale local emission inventories that capture the breadth of traditional and non-traditional sources of air pollution and utilize state-of-the-art air quality modeling to understand local, transboundary, and source sector contribution to local air pollution and health impacts. The new WHO guidelines can be applied to these insights to further risk communication and build community and stakeholder understanding of source awareness to deliver interventions that lead to sustained, equitable progress on cleaner and healthier cities. Thank you.
Thank you, Ananya. Great presentation, and thank you so much for also bringing us onto the ground, onto the city, onto the difference from one street to another, onto one area of the city to another, and also bringing us to what, as a cleaner catalyst, we are trying to do, using all the existing local knowledge as well as the knowledge that is also shared among the partners. So I will ask if Sumi and Michael comes to trying to answer some of the questions. As you have seen, some of these questions have already been answered by Sumi and Michael. So I will just try to see, well, some of you, the three of you, Michael, Sumi, and Ananya, have mentioned the importance not only of bringing these guidelines and the interim targets into the national level, but also the city. And you have also mentioned the importance of identifying sources and who is exposed the most. So would you have any comment on how to, I mean, Michael, you mentioned also that this interim target will help to develop policies, right? And also considering on the neighborhood or the community level, what can be, I mean, what would you see that, how to integrate these guidelines into the, like everyone in the cities, in the street? Do you have any recommendations for cities or communities on how to integrate this new evidence?
Yeah, I would say that, I mean, the very first thing is really to know where you are, so measure. And we have many different tools and actually Vital Strategies, for example, released an innovation guide, which is really directed towards cities, which provides lots of information on the current state of information, whether that means actually setting up an air quality monitoring network or using satellite-based tools. So first understand where you are, and then actions can be planned. And from the same sort of perspective, we also have tools, existing tools that can be applied to cities to understand the sources. And then if you want to do more detailed information on sources, more detailed studies or measurements can be done at that level. So really, those are the first steps. Understand what the situation is, and then plan actions accordingly.
And Beatrice, if I can just add to that, I think it's really important that we need the data, we need the technical information, but when we're thinking about source awareness with respect to the Clean Air Catalyst, we really want to make sure that the public awareness is also oriented towards those leading sources of pollution, because we do find that there are often misperceptions about what the leading sources of pollution are. And so we want to make sure that we can really have the right evidence that can then redirect attention towards those most impactful sources.
Thank you. Thank you so much. I see a question, Ayat. Would you like to ask your questions directly, or do you want us to read the question? One of the participants. Well, there's one comment, and I guess partially answered. This is important about sources and about, so the question is if there's any recommendation for jurisdictions, let's say, when you have non-anthropogenic background levels that are above the guidelines. And I guess this that applies for dust that is coming from outside, fires. And we also know that the high background levels in some cities of ozone, for instance, background levels of ozone. Do you have any comments? I mean, how to really try to focus on the guidelines, but also knowing the background levels?
Yeah, if I can jump in quickly out here. I think it's important for us to realize that while it might seem that background levels of dust and wildfire smoke and all of these other, extreme events that are happening, there is a component of emissions that are happening within cities that play a role in driving those, right? So, for example, you could even say that, transportation emissions, which are one of the leading sources of greenhouse gas emissions, and are continuing to grow, are playing a role in driving climate change, which are then supercharging wildfires, that are supercharging droughts, which are then increasing dust storms and other things across the area. So while you do have these background levels that are also coming from transboundary areas, I think we shouldn't completely dismiss them and say we have no control over it at all, but really dive into actions that can drive down emissions that may not directly get at those levels of air pollution coming from those, but drive at the root causes of those. So I think it's not something we can just completely wash our hands off and say it's not our problem and we can't do anything about it. I think there's a lot we can do about it.
And I would just add, the guidelines themselves are health-based, so really do not consider background levels to be any different. So that's really an implementation question. I mentioned there's a good practice statement on desert dust and sandstorm, and that was actually developed for exactly this kind of question. And it focuses not so much on the level or not, but what you can do about it, including how to reduce exposure, including how to forecast, and so many actions that can be taken. We know, and in the context of developing those guidelines, we have done reviews of the literature on desert dust, sandstorms, and that type of pollution does have adverse health impacts. So whether the source is mineral dust or is combustion, we are accumulating evidence on health impacts, and all these sources need to be considered in actions.
Yeah, thank you. And that's also related to, how not to discourage with this very tight and really, it's, as you mentioned, Michael, why do we have new guidelines if we are not able to, we are not actually meeting the existing. But the other thing is that, as you mentioned, the evidence, and even if you have this background level as well, as Sumi mentioned as well, and Ananya, you have a lot of sources that you can control, and the exposure and who is the most exposed. So I think that's a very interesting discussion. Well, we are finalizing. We really would like to invite all the participants to follow what we are doing as the Cleaner Catalyst. As have been mentioned, we are trying to not only gather evidence-based information, but also participating and collaborating closely with the local stakeholders and actually incorporating the knowledge and the worries and the perceptions that they have. So I will like to thank our panelists. Thank you so much. It has been a great discussion. We always, we could be even more time discussing this issue with you, with your experience and knowledge. Thank you so much. And I would like also to thank the participants, particularly the USAID staff. Please know that we, as the Cleaner Catalyst, will be launching a series of for staff of webinars starting on October 20th. So please keep informed, keep focused, and thank you so much. And have a very nice evening, day, and night. Thank you.